Sarah. I'm a nurse practitioner with the Yukon Sexual Health Clinic in Whitehorse, Yukon. And we are located on the traditional and ancestral grounds of the Yukon-Lindum First Nations. Part of our clinic is also our Opal Clinic, where we do options in pregnancy and long-term contraception. So I'm here just to chat a little bit about prescribing for medication abortion. These are just sort of an overview of our competencies specifically for our nurse practitioner education. And I'm just going to sort of highlight on some of the key learning points that you could consider including in your curriculum. So as Martha sort of touched on, both procedural medication abortion are highly effective and safe means of ending a pregnancy. They carry similar risks with respect to infection and ongoing pregnancy. MAs, we do know though, are associated with increased pain and bleeding, and they do take longer to complete than procedural abortions. But they can be completed in the client's home environment, which may be more desirable for clients and can improve accessibility, particularly in underserviced regions across Canada. So Mifegymiso is the Health Canada approved and SOGC recommended regimen for medication abortion in Canada. And again, as Martha mentioned, since about 2017, nurse practitioners can prescribe it across the country. It's a 2-dose combination product used to end a pregnancy, and it is considered effective and irreversible. And that's always sort of a point that I include when mentoring other new practitioners, as well as my own clients. It is not less, it's just as irreversible as procedural abortion. So mifepristone prepares that uterine lining for shedding. It promotes bleeding for endometrial degeneration. And then, of course, more of us could be familiar with the misoprostol, which is that synthetic prostaglandin, which induces cervical ripening and uterine contractions. So the regimen does come in color-coded boxes, which can help clients more easily follow it. Essentially, you're taking a 200 milligram tablet, and then 24 to 48 hours, you're taking 4 200 milligrams misoprostol tablets by the buccal roots. Most clinics, including our own, will have a patient handout just to sort of accompany how to take the medications and when to take the medications. At this point too, I would, include in education, just sort of instructions on how to complete any education around troubleshooting. So if I missed a dose, if I didn't take my misoprostol, if I vomited within an hour after a dose, and there are specific guidelines for that that I'll sort of provide sort of links to at the end of this. So when can we prescribe it? This is gestational age is obviously quite important for medication abortion. So Health Canada has actually approved it for up to 63 days in Canada, so 9 weeks. And it's considered just as safe as surgical abortion at this point. The SOGC actually has recommended an extension to 70 days, so 10 weeks. Still quite effective at that point. There's no lower limit gestation for prescribing mifegymiso. We do know it is most effective in the first 7 weeks. So understanding our gestation is obviously a super important part of nursing and client education. So previously, ultrasound dating was mandatory, as Martha was mentioning. And ideally, we still can complete an ultrasound, particularly if we're uncertain about last menstrual period, those sorts of things. But yeah, in 2019, Health Canada approved those guideline updates that allow prescribers to use their clinical judgment on determining dates and ruling out ectopic. And SOGC has great resources, sort of checklists about going through that history to look for those symptoms and risk factors for ectopic pregnancy. There are absolutely contraindications to medication abortion, which I believe should be highlighted in nursing curricula. Ectopic pregnancy, once again, is one of them. So whether that's a known ectopic pregnancy or a high index for suspicion, and ambivalence. And I think it's important to note that at any point during the medication abortion prescribing process, if we are detecting ambivalence, to offer that time, additional time in counseling about other options in pregnancy. And anyone in the healthcare team can actually do this. Pharmacists themselves can actually hold dispensing the medication as well, if in their discussion with their clients they are finding sort of themes of ambivalence as well. A lot of relative contraindications that should sort of be reviewed in terms of bleeding and hemorrhagic disorders. We get a lot of questions from students and clients about IUDs. They just essentially have to be removed before we go ahead with prescribing for a medication abortion. And then, of course, with any sort of prescribing of medication, reviewing the patient's allergies, comorbidities, concurrent medications, there could be potential client-specific contraindications, and those may include mifepristone does have a slight anti-glucocorticoid property to it. So our patients who are dependent on cortisol replacement therapy or who have severe asthma attacks, mifepristone may be contraindicated for them. Really important to go over sort of expected and adverse events when prescribing mifeguy-miso. Vaginal bleeding and pelvic pain with cramping occur in nearly all cases of medication abortion. And really there needs to be a very specific discussion and counseling on what is acceptable bleeding and versus what is excess bleeding. For example, in one of our handouts, we'll often give, it is normal. You could be passing, the clot size of a lemon. However, I don't want you saturating, 2 maxi pads in an hour for 2 consecutive hours. So those would sort of be, again, very specific for nursing students as well as clients to sort of be able to outline those during the medication abortion process. A really key note here too, prescribing of analgesia is not optional and should not be viewed as needed. It should be part of routine medication abortion care. These are just sort of other common side effects. Again, a lot of this just speaks to actually knowing the medication, getting to know the mechanism of action. A lot of the common side effects are actually related to the misoprostol itself. It does give you sort of like a 24-hour flu, and that's expected. Also offering, in addition to analgesic, the option to prescribe other medications to assist with these common side effects during this process for these clients. There are abnormal outcomes and complications associated with medication abortion. And as Martha mentioned as well, a lot of these are similar to procedural abortion. The management of these is obviously going to depend on what is actually happening with your client. So it could include prescribing more misoprostol, sending the client to the emerge just to sort of assess for hemodynamic stability, or referring for procedural or surgical termination if needed. So knowing the potential adverse events and then the right steps to manage them, even if that's not you managing it yourself, even if you're not a procedural abortion care provider, but knowing where to send those clients is an important part of education. When we prescribe medication abortion, ideally clients have access to urgent care for 14 days at a minimum 7 days. Arguably the most important part of, and this was sort of spoken about earlier by, appreciating the lived experience, but arguably the most important part is our pre-counseling. Medication abortions are painful, and they can involve a significant amount of bleeding. And then we also, the medications themselves can induce this 24-hour flu. So, so going over these with clients very clearly and taking that time, particularly in our clinic, we found sort of reduced emergency visits, reduced anxiety levels of our clients, and overall more positive feedback about how this experience was for them when we see them in follow-up. So hugely important, that pre-counseling piece. We also like to The timing of completing the regimen is really important as well. With the cramping, the bleeding, those sorts of things, of course, this is going to interfere with, perhaps work life, day-to-day activities. So having those additional personal supports, whether it's childcare, an actual support person, transportation, those sorts of things, is an important piece of the counseling. At Opal, we actually provide our clients with our personal numbers so that they can call one of the practitioners if they have any questions or concerns during this process. And sometimes it could be as well prescribing more analgesia, but we really want them to feel supported and have someone they can reach out to, particularly in obviously rural areas or in clients who may not have as many home supports. And then, of course, counseling and follow-up. Follow-up does need to include confirmation of completion. And so ideally, this is completed within the first week or two. And this is something that we also, sort of mentor our clients and new practitioners on. Ideally, we could do this via ultrasound or serial quantitative beta HCG measurements. This is not mandatory anymore, though, as well as Martha mentioned. So in our minimal contact abortions, we actually can complete the follow-up with a phone call, assess for symptoms of pregnancy, and then maybe have the client do a home pregnancy test in about 4 weeks. And then, of course, follow-up care should also include direct provision or referral for additional psychological and emotional supports. We don't know how everyone is going to react emotionally to a medication abortion. And we shouldn't always assume that they're going to need these supports either, but it should definitely be a conversation offered to them. And then just a final note about contraception counseling. This should be as well included in abortion care. It can be offered at the time of prescribing the medication, follow-up of prescribing or confirmation of completion, or at an appropriate allied clinic, such as a contraception or birth control clinic. We try to offer these conversations or offer the discussion at each sort of point of encounter of the medication abortion process. One of the reasons as well is if they do decide to go ahead with procedural termination abortion, we can actually, and they want an IUD, we could actually potentially insert that IUD as at the time of the procedure. And then we're also mitigating further pain and discomfort with IUD insertion. So just a little point to sort of bring up to students to chat with their clients about contraception during this whole process. Tons of resources out there to assist us for prescribing, and some really good resources with sort of pre-done consent forms. Like I mentioned, we always, at the Opal Clinic with the Yukon Sexual Health, we always had to do a patient handout for actually how to take the mifeguy-miso, because with everything else going on and having to go through this decision-making process, we're giving a lot of information, kind of like I am now, and understandably, they may forget sort of the timing and the details of that. So below is sort of some of the resources that we use to develop this presentation, but also that we near our clinic after, and that maybe will assist in developing curriculum as well. And that's it.